Hello, everybody. Welcome to the PICU curriculum teaching on Wednesday the 2nd. We're going to be talking about management of pain and sedation on the PICU. Right, let me share my screen. Okay. Okay, so I guess the first thing is what sedation is. So essentially, sedation is something that's administered pharmaceutically, and it's classified as a reduction of irritability or agitation by administration of a drug. And generally it's done to facilitate medical procedure, which may be intubation and ventilation, maybe maintenance of sedation on PICU, or a procedure. So relatively straightforward. So how do we assess people's level of irritability or agitation or sedation or whatnot? And so we have to have a system by which we can validate it and which we can compare patients and whatnot. And essentially there's a whole variety of different scores we can use. And they're kind of all validated scores, and most of them take up different categories and look at various variables: heart rate, blood pressure, alertness, calmness, movement, muscle tone, crying, things like that. And I mean, we tend to use comfort B, and there's a whole variety of different scores that can be used. I worked in places that use FLAC, other things. And so the important thing is that you have a way of measuring people's sedation or their lack of, and that's comparable, objective, and accurate. And I mean, the comfort score basically takes on many different parameters. And a comfort score and specifically looks at alertness, calmness, movement, tension, tone, and crying. And so it gives you a score. Up to 20, well, 22 is a kind of sedated score. Anything below is excessive, and anything above is inadequate. But pain and sedation go together. So I'm going to talk a bit about pain, although I'm not going to do a whole review of it. And I mean, essentially, there are certain commonly accepted parameters by which we measure pain. We know all that. There are well-recognized drugs we can use to manage pain. And the basic concept of a pain ladder, which basically means that as your pain increases, in other words, you got the ladder, there are different agents you can use as you got the ladder. And we all know what starts at the bottom, the paracetamol, ibuprofen, and that kind of scales up to opiates, enteral and IV, and plus a whole variety of other anesthetic agents. So normally in general pediatrics, you might go up 2 steps on the ladder, but in ICU, we may go up 4 or 5 steps on the ladder. There's a whole variety of drugs that we use. This is just an example of some of the opiates that we use. So those of you who have worked, I mean, if you've worked here a little bit now, and you've seen us using morphine, you've seen us using fentanyl, which essentially is a very more potent opioid, with a shorter onset of action and a shorter half-life. Remifentanil, which has another opiate, which has a very rapid onset of action, but a very short half-life and a very quick metabolism. And there are some other opiates. I mean, methadone we don't use very often, but I mean, if you take in general, if you go, one of the things about ICU that you realize as you travel around the world is that there's not that much deviation in practice. Most people use opioid analgesia, and most commonly fentanyl. I mean, it's most commonly morphine and then fentanyl. And if you think about it, considering there's no particular written consensus, or hasn't been for a long time, the fact that they've all got to the same place is kind of a remarkable thing, really. But in other ways, it does reflect the fact that we don't actually use that many different drugs. So I'm not going to go for a whole literature review of morphine use. I mean, there's countless studies that have been done over the last 30 or 40 years about its efficacy in general ICU, cardiac patients, neurosurgical patients. And as new as new opiates come along that are more potent and more short-acting, then people have amended their practice to try to use them a bit more, but in some kind of contextual situations. The classic one being a child who may be tolerant to high-dose morphine, and you might decide to use a more potent opioid. Or, for example, a child that might come back from theatre that needs just a short duration of potent analgesia, and so they might be on remifentanil, for example. So opioids are opioids. Again, I'm not going to go back to medical school and teach you how they work, but I mean, the most important thing is we have different potencies of opiates that we use, and but they do have different potencies, but they also have different side effects. In which case, you know, sometimes we do use them related to their side effects. So, for example, morphine classically causes pruritus, and it more causes bronchospasm. And the thought is that some of the more potent opioids, that's decrease in incidence. So we decided we may use different things. This rigid chest syndrome is something very particular to fentanyl, and so, for example, certain patient groups like broncholytics, you might want to avoid fentanyl, for example. But they all have their own profiles. And similar thing with morphine, in that, you know, we know that patients who have renal failure, and we've seen that on the unit ourselves, in that ones who have an active metabolite, morphine has active metabolites which are cleared by the kidneys, and so that trying to hang around quite a long time. And then, as I said before, contextually, things like remifentanil or fentanyl are used a bit more, depending on the context in which you want to use them. But if you ask me about what's the evidence for this and what's the evidence for that, there's not a lot. Death means not a lot. So certainly there are situations where adult practice colors what we do, and so adult practice, they use paracetamol a bit more, and certainly we're using it a bit more. The other group of sedative drugs are opiates, are benzodiazepines. So benzodiazepines, we all know, and again, they kind of are, their action is modulated via GABA, on the GABA receptors, and there are particularly good things about benzodiazepines in that they reduce anxiety, they sedate, and they also produce amnesia, which is very useful if you're in a nasty place like PICU. And so it can produce amnesia. But I have to remember that it's not, there's no analgesia, so, you know, having people just on benzodiazepines is not adequate. And again, you know, it's important to know a little bit about their onset, about their half-life, and about their elimination time. In other words, how long they hang around. Midazolam and lorazepam are the most frequently used benzos, and we use midazolam quite a lot as our standard infusion during acute illness. But it is important that we do know a little bit about the toxicity and also the side effects. And so we use an appropriate dose that we can use. So again, a little bit like I was talking earlier on this week, that morphine and midazolam both have active metabolites that are renally excreted, so we have to be careful in renal dysfunction, and we've seen it ourselves that patients on these drugs with renal dysfunction, they do tend to hang around quite a long time. Lorazepam and midazolam are potent anticonvulsants, but also sedatives, but it's important to know that they do cause a respiratory depression, and so, you know, the classical thing is a child comes in with a seizure, gets a benzodiazepine, stops breathing, and then intubated and ventilated. And they do clear differently depending on, one, the amount of fat you have, because they're very lipophilic. Also, they depend on your renal function to be eliminated. And as I said before, is that some of their effects are actually potentiated by morphine. So respiratory depression is greater if you combine morphine and midazolam as opposed to either one on itself. One of the things also that is important to recognize is that we deal a lot with withdrawal. In other words, children are on a relatively high dose of sedation for a period of time, and unless you wean them in an appropriate way, and you use opioid-sparing agents, and you may use drugs to reduce the effects of withdrawal. Withdrawal have been seen with both morphine and midazolam, and one of our jobs is to try to establish which one they might be withdrawing from, but often they're withdrawing from both, and so you have to treat that appropriately. But there is a withdrawal phenomenon associated with both of those drugs. Also, what we've now come into using a lot more are alpha-2 agonists. Now you are maybe asking, oh, why is, you know, an alpha-2 agonist a sedative? But so their effect is central. Their effect on central alpha-2 receptors. So the important thing is that the centrally mediated effect predominates, and then but however they do cause other effects. So they cause bradycardia, can cause hypotension. So alpha-2 agonists that we use, the most common one is clonidine. And but you know, as in many other parts of the world, they use dexmedetomidine, which I personally have used a lot, quite a bit. Other people have used as well. So they're the primary alpha-2 agonists that we're using for centrally mediated sedation. And obviously, and then we are kind of putting up with both their peripheral effects and other effects. They also are used as opioid sparing agents, and I'll come on to that when I talk about delirium a little bit. And they do produce some analgesia too. So I mean, the advantage of clonidine is it can be given orally, it can be given intravenously, both as boluses, and it can be given as an infusion. I put down it's also can be transdermal. I don't use transdermal clonidine, but I think there is a preparation. And as I said before, is that there is a thought that the sedation produced by alpha-2 agonists more closely resembles natural sleep. And so sleep disruption, which is one of the big things about being on intensive care, can be diminished. Also, as I said before, is that they do have an analgesic effect, but they also centrally can affect pain perception. And so they can work from that point of view. So you can understand that as a relatively new set of sedative agents, you know, they have quite a few different mechanisms of action, which are only really starting to understand. Again, there's a concept of arousal, in other words, how you wake from sedation, and also how you go into sedation. And again, there's a thought that alpha-2 agonists produce that bit more smoothly by kind of trying to induce natural sleep. One of the good things also is that the respiratory depression is meant to be less than opiates and benzodiazepines. And so in a patient in which you are trying to, for example, sedate, but not necessarily are worried about respiratory depression, or you're trying to reduce that, then that might be a more useful thing to use. And particularly, you know, I've used it a lot, particularly in patients who just need sedation for a relatively short amount of time, because I mean it's basically dexmedetomidine does clear the system quite quickly. But however, almost paradoxically, although they're opiate sparing and they can be used to treat some of the symptoms of withdrawal, there is a tolerance and a withdrawal syndrome associated with alpha-2 agonists. I have to say that I haven't seen very much of it, but certainly with prolonged use in adults, it's well described. So then I guess when we come out of thinking about opiates and benzodiazepines, the next most common drug that we're using is propofol. Now, propofol is an IV anesthetic. And basically, again, it's a GABA, it goes through the GABA pathway, and it produces sedation and anesthetic. But most importantly, I have to remember that it's not it's not analgesic. We use it quite a lot, and really the important thing about it is it's used with care, and it's used by people experienced using it, because it can have quite profound side effects. So as I said before, it's got no analgesic properties, but is a very potent sedative and anesthetic. Also, it's a very potent anticonvulsant, and it has been used, and we've used it ourselves to prevent seizures. And it's very characteristic because it's white, and that's because it's a lipid emulsion. So, you know, those of you that have ever had anesthetic or would do anesthesia, you see a vial of white stuff, more than likely it's propofol. And but when you give it, it does cause pain in the injection site. So children often wince, and you can mitigate that by using lidocaine and other things to try to reduce the effects of that. As you guys will probably know, it's a rapid onset. So, you know, for example, when you go for an anesthetic, they count to 10 or count backwards from 10 and give you the syringe, and you never get to 1. You normally sleep by 3 or 4. But it's rapid onset, but it also comes off rapidly. It doesn't last very long. So it's important that it's maintained if you're going to use that as an infusion. And as I said, children do require, obviously, frequent neurological assessment when having it. And it's not always used, in patients who are intubated on ventilators. It's often used, procedurally. Like, for example, on daycare, they use it for their procedures and things like that. You've probably seen LPs, bone marrows, all that sort of stuff. And in A&E, sometimes if you, just look at your shoulder, they might give you something like ketamine or some propofol or something at sort of low dose, not enough to produce a respiratory depression. But one of the things is that it does produce respiratory depression. I mean, that's good for an anesthetic, but not always good for other things. And it does get you to lose your airway reflexes. But the thing that we see most often, it causes a very profound hypotension, and which is mediated by a combination of vasodilation, which is at a lower dose, and at a higher dose, it can cause myocardial depression. So you have to be very careful using it. And that's why you wouldn't necessarily use it in children who are septic or hypotensive. You would use it more electively, or patients, for example, who come with a neurological presentation in which they've got a normal cardiovascular system. That's much more appropriate. But the reason that adults use it routinely and children don't is because of propofol infusion syndrome. And so essentially there's a syndrome described by which if you use propofol for relatively long periods of time, and we've deemed that anything above 12 hours, there is a risk of this syndrome which produces rhabdomyolysis, lactic acidosis, and then that goes on to produce cardiac arrhythmias and myocardial failure. And it was noticed, historically it was noticed in a small group of children essentially. But now, the upshot of that is that we don't use propofol as an infusion for more than 12 hours. We don't really know why it's caused, but there's a whole kind of, feeling. But essentially, it's probably due to suppressing mitochondrial metabolism. It was described, I think, in I want to say the early 80s, but pretty. The time that I was training propofol was already off the chart. Although tolerance and withdrawal have not necessarily been described with propofol, it is a drug of abuse, so there must be something that's going on. Sorry about this slide. I don't know why it's so. This is what happens when you do from Apple to Microsoft. Okay, this is Matt actually found it was 2 slides. So the other drug that we use is ketamine. So those of you that, I'm sure, you only have to watch EastEnders to know about ketamine. So ketamine is a dissociative anesthetic. And what that means is that it dissociates your sensory inputs from action and awareness and arousal and all that sort of stuff. So, the most famous dissociative drug is alcohol. So they produce a similar effect, not quite to being drunk, but it's the same thing, that you can ingest it and just slightly numb everything, your perception of pain, your awareness, your wakefulness, all that sort of stuff. But the thing about it is, so it does produce analgesia, it is a sedative, and it does produce amnesia too, so which is all good stuff for ICU. It's predominantly used in patients in which you're worried about their cardiovascular system. In other words, it's meant to be relatively cardiovascularly safe. In other words, it produces less profound hypotension than some of the other drugs that we see. And often with a child who's hypotensive, whether it's kind of hypovolemia or maybe sepsis or things, often we'll advise use ketamine in place of that. However, it's important to be careful of that, because no anesthetic is safe, and you have to titrate every anesthetic to effect. But also its safety relies on your endogenous sympathetic activity. So if that's blunted in any way, for example, if you're on inotropes, that massively reduces the cardiac safety of it, because if you're on inotropes, your endogenous production of catecholamines goes down, and so you're less likely to be able to preserve your cardiovascular stability with it. So that's very careful that you know about that. Respiratory drive is uniquely preserved with ketamine, even to quite high dose. But obviously, like any anesthetic drugs, it does stop you breathing eventually. And we tend to use, ketamine has become very popular in procedural anesthesia. And so if you're having a procedure, often, I mean, in ED, you'll see people using it. You'll see them, and sometimes we use it here for procedures because it's very good, particularly in the non-ventilated patient, because respiratory is preserved a lot and it produces analgesia and it's slightly sedative. So that certainly means it's used as a positive thing. One of the other things that is important about ketamine, useful, is that it is quite a potent bronchodilator. And so often in patients who have profound bronchospasm, for example, patients with asthma, sometimes as a sedative, we'll use ketamine for that. It is important, though, that, I mean, ketamine does produce rhinorrhea. In other words, it increases secretion. So you have to be careful, particularly in asthma. Some subsets of asthma, predominantly, the feature that you see with the wheezes, excessive secretion production, and specifically difficulty clearing secretions. In those patients, you have to be careful with ketamine. Also, the thing is that you get hypersalivation, you get increased bronchorrhea, and it may trigger laryngospasm. But so it's important, if you see that, to be able to offset that with muscle relaxants. There's always been this feeling and teaching that if you have raised ICP, you should not use ketamine. It's out. Exactly. I'm glad you said it. It's out. So when I was a trainee, it was almost like a thing that it was a taboo subject. You couldn't use it at all. Yes. So I have to say that we use ketamine quite freely in traumatic brain injury now. So I think that's old stuff. The next, sorry, yeah, go on.
So why the switch? What happened?
Oh no, the thing is, I think that it's just better quality evidence of its safety. That's all. Like many things, things can, there can be small case studies that show something, and then it quickly becomes, because it's hard to replicate, and they quickly become law and the gospel. But what you need is a newer gospel, and the newer gospel, says it's perfectly safe. So like I said, I have to say I never saw it in raised ICP, but any ill effects. But there you go. So the next group of drugs in this little overview is barbiturates, and barbiturates are probably the drugs that have been used the longest in medicine. They've been used from the 18th century in some variety or other, and they've been used quite a lot. And again, they're sedative, they're neuro dampening. They produce a very profound unconsciousness, and they do it via GABA. The most common ones that we use, as you know, thiopentone, phenobarbital, all those kind of things. And so they're extremely famous for producing extremely deep sedation, if required, but they're actually very potent anticonvulsants, which is what we use them mostly for, and particularly phenobarbital in children. And thiopentone particularly has been studied quite a lot, and it reduces brain activity quite a lot. And really what we're doing when we're trying to use it is we're trying to induce a state called burst suppression, which essentially is minimizing brain activity. And so via reducing brain activity, thiopentone does reduce intracranial pressure, it reduces cerebral metabolism, and it produces intracranial and cerebral blood flow, and which is all that we use as part of our neuroprotection. So you look at the neuroprotection guideline, thiopentone is there at the bottom. As I said, phenobarb is used quite a lot. It's a very sedative drug. It lasts a long time. It's very messy, but it's a very good anticonvulsant. So we use it predominantly as an anticonvulsant. Thiopentone, similarly, is a very potent barbiturate. It's got a faster mechanism of action, produces deeper sedation, also a very potent anticonvulsant. But the difficulty with the thiopentone is, like all barbiturates, they're extremely lipophilic, which means that they go into your fat cells and they hang around forever. So what the commonest side effects we see are hypotension, which is mediated via vasodilatation and at higher dose myocardial depression. But also it can cause gut perforation. It can go extremely long half-life, but particularly in the neuro patients, it can produce pupillary changes at high dose. And obviously in the situation we're trying to assess people's neurology, it's extremely important that that's an accurate thing and not affected by barbiturates. As I said before, is that thiopentone itself, you'll have seen it described using RSI as part of RSI induction, in which case it's a very good drug, but again, going out of fashion. Haven't seen many people using thio when they have other drugs at the moment. And similarly to maintain sedation. And I said we don't use it very often just because it has an extremely long elimination time. But still a very useful drug. Ignore, this is just an illustration of the facts that we have lots of different drugs we can use. You don't have to look at that slide. So I know we're relatively short of time, so I just wanted to give you just an overview of the class of drugs we have to use, their different mechanisms of action, how long they last, why we use them in certain conditions, what the pros are, what the cons are. And you know, this is recorded, so you guys can watch it later. Also, I want to spend a little bit of time about neuromuscular blockers. So it's important, again, as part of, you know, there's many conditions for which we are muscle relaxing patients. Classically, you know, potentially a child with bad lung disease, ARDS, difficult to ventilate children, traumatic brain injury during neuroprotection, they're all receiving neuromuscular blocking agents. And just so you know, there are two classes, depolarizing and non-depolarizing. SUX is the only depolarizing one. I mean, we use it in very select circumstances, primarily because its action is so short. Outside RSI, it really has very little value, to be honest. And even during RSI, particularly in a situation where we are going to be, most patients will have a prolonged time of intubation and ventilation, doesn't actually give you much benefit. We tend to much more use we tend to use non-depolarizing neuromuscular agents, primarily in different situations because of the different lengths of action. In other words, pancuronium is a very long-acting drug. We tend not to use that. You know, we use a lot more rocuronium as a short action. Some, you know, and we do use atracurium, and we use particularly atracurium, and I'll talk to you about why and when we use atracurium. So the mechanism of action, you know, to remind you of the neuromuscular junction, you know, the nerve impulse is transmitted across the synapse by acetylcholine, and it's broken down by acetylcholinesterase, and then that's kind of reabsorbed into the presynaptic nerve, and then that's essentially how the effects of acetylcholine propagated, and so they're blocking that. A different one class is essentially blocking the action of acetylcholinesterase, another one is preventing the reabsorption of acetylcholine. So, but I mean, as I said before, we use it predominantly for its length of action. So as you can see, pancuronium lasts hours. We don't want to do that. Most of the time we'll use ROC or VEC. It's important when you're doing RSI, you know what the onset of action is. If you only learn one thing about the drugs, learn their onset of action. In other words, how long you have to wait before the effect. So the nurse gives you rocuronium, you know you have to wait double the length. I mean, I keep it in my mind that you have to wait double the length of time. But the duration of action is similar, so you should be able to do RSI perfectly happily in half an hour, hopefully. And as I said, I mean, like, you know, the fact that SUX lasts a couple of minutes, I mean, you know, by the time you got the tube in and got it secure, 5 minutes goes very quickly. Atracurium has a very particular method of breakdown, something called Hoffman degradation, which essentially means it's broken up in the serum, which means you don't need, most of these drugs are renally eliminated, as you can see. You don't require that if you have atracurium because it's broken down in the plasma. That's the only reason. So, you know, particularly patients who have got hepatorenal dysfunction, you'll use it in preference. But like I said, it's not a huge effect. And we use neuromuscular blockade as in addition to sedation, right? So you have to make sure that you have established that the patient is well sedated. The worst thing in the world, I imagine, I hope it never happens to me, is to be awake and muscle relaxed. Can't be much fun. So that's why it's important that before you give the muscle relaxant, you establish they're sedated, and you regularly have breaks in it, if the clinical situation allows you to let you assess the level of sedation. So that's the important thing. And we do use muscle relaxants quite a lot, and we use it you know, if a patient with ARDS, or let's say an early asthmatic, which we do having problems with things like ventilation dysynchrony, you know, problems with chest compliance, lung recruitment, all those kind of things, then, you know, administration of anticonvulsant, of neuromuscular blocking agents is completely evidence-based. In other words, you know, there is evidence to show that it has beneficial effects in terms of how you ventilate patients, and that, you know, if you look at not necessarily morbidity and mortality, but length on the ventilator and all that sort of stuff. So it's perfectly acceptable and perfectly normal practice if you have a child with difficult ventilation and you have the muscle relaxant, you essentially take over. But what we're constantly trying to do is give them holidays, in other words, little breaks, and you're constantly trying to assess whether they need it at all. So that is an important thing. Same thing with TBI. You know, patients, we do muscle relax as part of TBI management, but actually there's not much evidence that in itself is going to reduce brain activity. But you can, common sense probably tells you if you're not, you know, if you're so sedated, you may kind of still move, and I guess if you're moving, you've got some brain activity. So, you know, it's not, there are many things in life that are common sense, but not necessarily there's great evidence for. You know, it's a difficult thing to think. But, you know, in those two groups are the ones in which we're really trying to muscle relax. Again, we do sort of common things. So there's no actually evidence that drug holidays do anything, but, you know, again, common sense tells you that intermittently should make sure that the patient is well sedated. And, you know, and protocolized weaning of sedation and muscle relaxant has not really shown any benefit. In other words, you know, especially in children, but it's not a bad idea to think, well, every day I'm going to just take the muscle relaxant off, and I'm going to take it off for 30 minutes and I'm going to see what happens. That's fairly common practice. Or you can, you know, or some people, they do things like they wean it by 50% or something. Or there's a whole variety of different ways that people can do that. But I mean, it's not protocolized because there's not really good evidence that it makes any difference. But I mean, common sense tells you simple. We have seen, again, the thing about the use of muscle relaxants and steroids together, because there is a particular effect and a potentiating effect they have on certain things, and that's on a condition called critical care myopathy, which essentially means that the longer you spend in ICU, the weaker you get. But there is evidence that use of neuromuscular blocking agents plus steroids does potentiate that. So we're very mindful of patients, and we have some at the moment who've had steroids and neuromuscular blockers, and they're both weak. Surprise, surprise. Right. That's a very quick overview in 40 minutes of pain and sedation. That's not enough. You need like about 5 days to talk about them all. But I wanted to give you a brief introduction into it. I mean, obviously, because you guys are relatively new, well, you're not new now, but to give you some idea and the reasons why we might use certain things over others. It is also important to recognize that, as everything we do in ICU, nothing is a free lunch, and nothing produces the beneficial effect without some downsides. So there's an increasing perception, there's an increasing study, there's an increasing interest in delirium. And so delirium is essentially, you know, if you look at the definition, it's, you know, disordered thinking and ongoing problems with consciousness and awareness of your environment. And most commonly that's seen after ICU, after periods of sedation. And so, again, it's really hard because people have only really started looking at delirium in children. And there's a whole variety of ways that people assess it. There's a whole variety of incidences. You know, there are studies that show it's low, there's some that show it's high, but we all know it's a problem because, you know, common sense, again, going back to common sense, tells you that children who have had sedation for a long time will withdraw, and they may well suffer from delirium afterwards. But certainly the introduction of delirium tools, in other words, ways to assess it, have shown us that, you know, in adults, certainly not just in the first few weeks, but often in the weeks, months, and years after ICU admission, there are disorders of, as I said, awareness, confusion, and perception of your environment. Again, you know, there are situations where you can use scores to help you decide, and people have done studies in preschool children and school children to see what the ongoing rates of these kind of delirium type symptoms are. But I have to say, one of the things that comes across very strongly in all these studies is that we're probably underestimating it massively. And so, you know, the different scores have produced very different outcomes and different perceptions. But I think that we all feel in the PICU world that we're massively underestimating the amount of delirium. But there's enough delirium so that people can look at what the risk factors for it are. And there's been a whole variety of things people looked at. Pre-existing conditions probably mean you spend longer in ICU, probably means you need more sedation. Those children suffer more delirium. Poor nutritional status. If you've been, if you have a cardiac disease, if you've been on ECMO, none of these things are, you know, necessarily telling you about causation. They're just related. You can stuck at yourself why they're related. Well, a kid on ECMO has been extremely unwell, may well have had lots of organ hypoperfusion, may have spent a long time in ICU, you know, so there's not like a direct link. It's just, you know, the sicker you are, the more delirium you get, I imagine. And similarly, kids with pre-existing delays and all that sort of stuff. And so what can we do to try to prevent? I mean, one, we have to recognize it exists, I think. Secondly, we have to find good scores to try to assess it. We need long-term study to see the effects of it. And you know, one of our colleagues is doing something along those lines. But also the thing is, what you can do is you can try to use different drugs. And so, I mean, people have looked at things like dexmedetomidine, particularly when it comes to kind of, you know, short ICU stays, and there's some evidence that dexmedetomidine might reduce the amount of delirium. But I mean, there's lots of other things that contribute to delirium, not just the drugs you're on, how sick you are, how much your sleep is disturbed, how much, you know, noise pollution you get, you know, how noisy the ICU, whether you have sleep breaks and all that. So delirium is a really complex thing. We're only just starting to, you know, look at it in pediatrics. We probably haven't looked at it enough. There's a lot more adult stuff, but it's really complicated. But it is one of the things we have to be, you know, I don't think it's unreasonable to say that the less sedation you're on, the less delirium you have. I think that's fairly standard stuff. Just if you want to go and read something, 2022, this year, there was a thing which is, I think, in PCCM, which is the international, essentially, consensus guidelines about use of sedation in PICUs. Thankfully, there was nothing particularly new in it. All the drugs I've described to you are described in that. The only other thing that is, the use of dexmedetomidine in lots of different environments. But again, the number one thing that's different about this is the recognition and the treatment, not treatment, but the recognition, the attempt to reduce the incidence and the long-term follow-up of delirium. I'm done. I'm going to turn the recording off, but I'm going to let you ask questions. Thanks very much. There we go.